So, agreed. Very, I would say, not discussed. I think that this is one of those things that people don't really talk about, but it has a tremendous implications for function. So, I also want to say that majority of these to be clinically relevant are iatrogenic. And so I titled my talk Iatrogenic Abduction Contractures because those are, I think, the ones that are more problematic. So we all know these things. The loss of the upper trunk unbalances and tightens the shoulder, as has been shown to us by both Chesko and Roger Cornwall. Denervation of the deltoid upper cuff leads to weakness and tightness of the deltoid teres minor, infraspinatus, supraspinatus, and the upper subscap. Then you have these shoulder contractures that because everything is tight, you get these abduction and adduction contractures, both crossbody abduction and adduction contractures and rotational contractures as well. When you look at the tightness of these muscles around the shoulder, they restrict motion, yes, but they also restrict growth. And this growth restriction leads to joint deformity, as you can see in this picture. And we know that the reason for this is the Hooter-Volkmann law. Compression forces inhibit growth and the tensile forces stimulate growth. And so with some internal rotation and posterior subluxation of the shoulder just because of the internal rotation, due to the unbalanced forces of internal rotation that are not countered by external rotation forces, you end up loading the posterior glenoid, which then undergrows and the anterior glenoid overgrows. And so you have this glenohumeral dysplasia that's accompanied by a loss of passive external rotation, past neutral, and that's been shown to us by Mike Pearl and others. And then you have this MRI as your gold standard. However, that requires general anesthesia. So Mary Beth Izaki and others have shown that ultrasound is fairly reliable up to 1 year of age. And what really we want to see is what is going on with the glenohumeral joint. And briefly put, is the ice cream still on the cone? If the ice cream has fallen off the cone, we have to get it back on somehow. So I think one important paper is Roger Cornwall's paper about the three-dimensional anatomy of the glenohumeral joint in these kids. And you can see that there's not only a retroversion, which is something that's been recognized for a long period of time, but there's also this declination that occurs. And when you combine that, I'm sorry, when you look at the mallet, right? The mallet has really been geared for a long time to look at external rotation. And interestingly, we don't have an external rotation in abduction and adduction, which I think is something that we've shown that really is different. And then Scott and Josh Abzug put in the last column or the last row, which is the internal rotation, which is the first time people started looking at midline function. And so we've been doing these tendon transfers, which are basically modifications of the Hoffer procedure, and everyone has their own brand or their own label or their own way of doing this, but the tendon transfers can be done without a release. You can decide to do one or the other, either the lat or the teres or both. And then there's this inferior or anterior muscle and capsular releases, which were shown to us by the Boston Children's Group. The problem is that we've really not understood the deformity of the shoulder. So here's your normal shoulder, and you can see that the supraspinatus, infraspinatus, and teres major give you this line of pull in abduction and external rotation because the center of rotation here in this white dot represents that anything directly above it is going to give you abduction. Anything posterior to it is going to give you external rotation. Once you have deformity, linear typical glenohumeral joint deformity that happens with these brachial plexus injuries, you end up with the supraspinatus becoming an internal rotator and the external rotators becoming abductors. And so Stephanie Russo and our group has shown that the glenohumeral angles after tendon transfers without a reduction or with a closed reduction or with a surgical reduction, meaning we had to release something to get the joint in, you can see that the angles change and you start getting abduction contractures. And this is throughout basically every position. And what we found, which is really interesting, if you look at the second row, or second column, I mean, you will see that the amount of abduction you get really follows the abduction contracture that you get. So a 30-degree abduction contracture will augment your abduction by 30 degrees, which is something that makes intuitive sense, but we didn't know that. And what's interesting is when we looked at the arcs of motion, it didn't really change. So the arc of motion was translated, but was not extended. So we found that closed and surgical reductions were associated with increased glenohumeral elevation in the neutral position, and it corresponded to the glenohumeral abduction contracture. So the amount of additional abduction you got from these tendon transfers had to do not with the muscle becoming more effective as an abductor, but actually with the contracture that you created in the joint. And these closed and surgical reduction groups demonstrated, therefore, greater humerothoracic elevation. So surgical reduction, we found, had the worst perceived outcomes in terms of patient satisfaction and in terms of their ability to carry out their activities of daily living. It worsened the putty sign, and there were a larger proportion of these patients that were in the C5, C7 injuries rather than just an upper trunk injury. So there's something about the injury of C7 that makes this even worse. So the surgical reduction had a higher rate of loss of midline function. And what's interesting is abduction plays a part of this. Patients who require surgical reduction at the time of tendon transfer can be expected to have greater abduction contractures, which is an advantage. And it's something that we've been looking at as a positive thing for probably the last 50 years because they get greater overhead motion. The disadvantage is they have lower perceived outcomes with the activities of daily living, and they sometimes lose midline. Why? Why is this happening? Well, if you look at the relationship between the coracoid and the glenoid, as was shown to us by Chesko and Scott, you'll see that the coracoid actually becomes posteriorly dysplastic. So it hooks towards the humeral head. It's closer to the humeral head. The physis is more retroverted and perhaps tethered by the coracohumeral ligament. So here's the coracohumeral ligament, and you can see it's not as small as you would think, and it's attached to essentially everything. Here on the picture, it's the number Roman numeral 3, and you can see it going from the coracoid to essentially everything around the top of the shoulder. So, generally speaking, all procedures that push the humeral head anterior in a dysplastic glenoid will encounter the beaked coracoid and be forced downward along the declined glenoid. So Chesko showed us that the coracoid is in the way, and Roger showed us that the declined glenoid forces the head down with reduction. And this combined with the tightness of the supraspinatus and the infraspinatus, as well as the upper subscapularis, which is 5-6 innervated, will cause this abduction contraction because you're basically forcing the head down while maintaining the tightness of the upper cuff. And these abduction contractures, again, they give you an improvement in abduction, but it limits your hand to belly or midline function, and it worsens scapular motion and the putty sign. So schematically, it looks something like this. This is your normal joint. This is your dysplastic joint, and you can see the change in the coracoid if you look, right? If you put that back, you're going to hit the coracoid and have to be forced downward along this inclined or declined, I should say, glenoid. So one of the things that we've started doing to try to prevent this abduction contracture, which does limit your abduction gains, but it maintains a lower risk of loss of midline, is coracoidectomy as an adjunct to shoulder release, with or without tendon transfers. And the other thing that we've been doing, the other thing we've been doing is we've really reevaluated whether or not you really need tendon transfers. And I'll show you in this case. So this is Abel, 2-year-old with a right brachial plexus birth injury, primary surgery at 8 months, grafting for 5 and 6, spinal accessory suprascapular, and there was a tight shoulder with less than 20 degrees from neutral external rotation. And ultrasound showed humeral head subluxation. And here's the MRI. And what's really interesting, and when I talk about the need for tendon transfers, look at this infraspinatus. Oops, sorry. Look at this infraspinatus here. That is a pretty good infraspinatus. You see the deltoid is in actually pretty good shape, but the problem is the axis is way over here, and it is not going to move normally, that shoulder. So our sort of sea change for us has been recognizing that the kinematics of the shoulder are altered by the glenohumeral dysplasia, and therefore you start to get changes which affect how the shoulder moves. So this is basically the procedure. This has been shown by others. This is not new. Right shoulder, there's your cephalic vein in the middle. Find that. That's your main landmark. Then we do a coracoidectomy, isolating the coracoid with a bipolar electrocautery. And then you can see the subscapularis tendon. We've actually more recently followed the advice of Pablo Zancoli, and we really try not to cut the subscapularis, but instead focus on the coracohumeral ligament. And we found that you can get a fair amount of external rotation without the risk of loss of midline that we're seeing with subscapularis rolled border cutting. So here's an example of what Scott calls Old Mother Hubbard. She looked in the cupboard and the cupboard was bare. So the glenoid, you can see, but there's no humeral head. And that's because the head is posterior. So here's our reduction. Boom. You can see the head pop right into the front with external rotation and pop right back out. And if you're lucky, you get this kind of a clunk, because that means that you have a biconcave glenoid and you can reduce it onto that anterior facet. Here it is from the back, internal, external, internal. And you can see it's subtle, but there's a little abduction contraction. Let me do that one more time. That you get when you abduct. And that's even with a coracoidectomy. Okay, so our anecdotal results study right now is in progress, and we actually have some preliminary data. There's better motion than an arthroscopic release overall, but there's less abduction contracture and therefore less abduction if they didn't have it to begin with. But there's a lower risk of loss of midline as a result, and patients generally are happier. This is the problem. This is what you get with an open reduction from the inferior reduction without a coracoidectomy. And you can see she has a nearly 90-degree abduction contracture with that scapula. And she hates it. Yeah, it's really hard for her to get to midline. She walks around with her arm up, and this is a big problem. So the way we used to address this, and I think that it's still a reasonable thing to do, is this triplane osteotomy, where we cut the bone in 3 planes and plate it so that we correct the abduction deformity, the extension deformity, or should I say the flexion deformity, and the the external rotation deformity. And we did a study many years ago in techniques in hand and upper extremity surgery, where we showed that if you rotate a certain amount and cut at a certain angle, you'll end up with a certain correction both in the sagittal and coronal. And there are tables for this, so you can plan your osteotomy accordingly. What I'm doing now is this. Here's this Jackson, one of my favorite patients. He's 12 years old, and 10 years ago, he had a teres transfer. But he's really unhappy with his abduction contracture. He's really unhappy with the appearance. He's unhappy with the fact that he can't pull up his pants or button buttons or tie his belt. But he is happy with his overhead, and he's happy with his external rotation. So is there any way we can possibly preserve while improving? So we started looking more closely at the glenohumeral joint, and started doing more three-dimensional imaging of the joint, which I think really helps. And generally, when you're speaking about treating these kids, they're older and they can undergo a CT scan. Here you can get a sense of the abduction contracture, and you can get a sense of the declination of that glenohumeral joint. It's not as pronounced as you think it is because it's actually the scapula is tilted downward as well as the joint. And when we compare it to the contralateral side using 3D modeling software, you can clearly see on that axial view that the coracoid is posterior to a normal coracoid, and you can see that as well on the lateral view. What's also really interesting is the change in the morphology of the acromion. The acromion is not the same. And you can also see the hypoplasia of the scapula itself. So we planned this type of surgical correction with an improvement in the position of the acromion, the glenoid osteotomy to improve the shape of the glenoid and push the head forward. And this was sort of our final construct with the coracoidectomy. And you can see that had we not removed the coracoid, it would have been in the way on the axial view. But that's not actually what we did. What we did is we did the glenoid osteotomy, and then we found that as soon as we cut the scapular spine, we ended up with a gap between the one side of the cut and the other. And I actually just filled this in with the coracoid and plated it. And that's what you see there. And that really changed the look of his shoulder. It brought the scapula down, and it allowed lengthening effectively of the deltoid. Now, you would think that that would take away some of the abduction, but really did not affect his abduction. Here he is on the left, he's 6 months out, and on the right, he's a year out from the surgery. And you can see, there he goes. Look at his abduction. That's pretty good. His external rotation, we did have some loss, but he still functionally gets to where he needs to be. And now he's cheating with the internal rotation, but yes, he can reach midline. His appearance is much better. His putty sign is much better, and he's overall very happy. Pre-op, he looked just like that girl that I showed you earlier. So we keep a bunch of the stuff on little arms, including the PULM Talks. And that's all I have for this morning. I'm happy to take questions. Thank you.
Thank you, Don. That was amazing. Very, very interesting. Actually, we have some few patients where we saw that very severe abduction contracture. Even worried to do any surgery for them because I was wondering if we correct an abduction contracture, whether they will have loss of abduction. Yeah, but
So
your
I think
last
if you're
example
going
was
to
quite
do
interesting.
I was going to say, Praveen, if you're going to do it through an osteotomy, yes, you're going to exactly lose what you gain. So
Yeah.
I think that I've gone much more, these days I do more glenoid and scapular osteotomies than I do tendon transfers, just to give you an idea of where my head is right now. Now, that could change tomorrow, but that's sort of where we are.
Yeah, true. So these patients were more, as you mentioned, it is an iatrogenic contracture because of tendon transfers. Do you think the practice of giving an aeroplane splint is also another reason why many children may develop abduction contracture?
Absolutely. I think that's very true. I think one of the things that Peter Waters talks about is they do not splint as long as we do, and I think their loss of midline risk is lower. So I think this is true. But I think that overall, if you think about globally, the management of the shoulder, right? I think the magic really is in keeping these kids from getting glenohumeral dysplasia. And what that means for us is a teapot brace like the Helsinki group showed. And since we've adopted that, we've had, well, I would say so the refocus on the shape of the glenoid combined with the teapot brace has meant that I mean, I'm probably down to one tendon transfer a year, maybe two. It's really rare. It's really rare for me these days. And especially when you look at the MRIs on these kids, they have fairly good infraspinatus. Now, I think the other paradigm shift that Bertelli and Chesko have shown us is that when there's a lot of this co-contraction around the shoulder. And what they will do sometimes is they will wait until the muscles are reinnervated, and then at around a year and a half to 2 years, they will do a spinal accessory to suprascapular transfer just to ease that co-contraction. I think you can achieve that in some ways with a Botox, but not every time. And so I think the combination of that will also help improve shoulder function. But yeah, the abduction contracture is something that patients really, really hate, and it's something that we've not understood.
Yes, true. Yeah, patients really hate, especially as you showed in one of the videos where the reduction is happening in about 45 degrees of shoulder abduction. With so much of external rotation, if the shoulder is getting reduced, I think that patient is surely going to get an abduction contracture over time.
Yeah, yeah. And I think Roger's work is really interesting because we didn't know that deformity of this declination angle.
True.
Yeah, and I think that combined with the coracoid, the coracoid's really interesting because I'll do this, I will try to get a reduction, and the coracoid really is in the way. And once you cut the coracoid out, you'll see that the head translates into the space where the coracoid used to be. It's pretty amazing to see it
True.
happen.
True. There is a question in the chat box asking about what do you think is the incidence of the abduction contracture? If you could give a number.
So pretty much every patient with a slightly to severely dysplastic glenoid is going to have an abduction contracture. Even without any surgery. The question is how much, and if you are going to do a tendon transfer, um, if you do any kind of reduction, and what that means is, so if you do a tendon transfer on a child that has a minimally to not dysplastic joint, and those are the kinds of patients I think that most benefit from a tendon transfer. So their joint looks good, but so the kinematics are fine, right? But they don't have the musculature, or they're co-contracting, right? So you do a tendon transfer on them, or you do a nerve transfer or some way to restore external rotation. Those kids are not going to get very substantial abduction contractures. But anything that requires any kind of reduction, where you are moving the head from posterior to anterior, and you're not removing the coracoid or the coracohumeral ligament, you're going to get a very severe abduction contracture. That is actually, I think, it correlates exactly with the amount of dysplasia.
True. Thank you so much, Dan. If there are no further questions, now we'll go to the third talk, which will be by Dr. Whelan.